name is Gwen Jackson, and I'll be conducting a video of the thoracic and cardiovascular system. Upon the start of my assessment, I will enter the room and introduce myself and my position to my patient. Hi, Tanika. My name is Gwen Jackson. I'm a registered nurse, and I'll be conducting an assessment of your cardiovascular, which is your heart, and your thoracic, which is your lungs. Are you in agreement with that?
Yes.
Okay. Upon introduction of myself, that's when I've begun my assessment. I am looking at her chest wall at the inspiration and expiration. At that point, I'll be observing for symmetry. I'll be observing for retractions. I'll be looking at her color to determine if they are appropriate, as if she's ashen in color or blue or cyanotic in color. That could indicate that there's not the proper oxygenation. I will also test her capillary refill. Whether it's less than 3 seconds will determine that she has normal capillary refill and appropriate circulation. I will also be observing for swelling. Swelling can indicate a fluid buildup. So at the beginning of my assessment of those two systems is inspection. I'm looking for her breathing. I'm inspecting. I'm looking for her at her color to determine if that's normal. And I'm also inspecting or looking for swelling. At that time, I would then, I can take my stethoscope out. I hit myself in the face. But I will begin the percussion phase. And I'm going to do this anterior and posteriorly, starting at the base of the lungs. Hypersonus. Going on both sides. Noting that the right lobe has, the right lung has an extra lobe. Then I will auscultate or listen to her lung sounds with the diaphragm of the stethoscope. Deep breath in, deep breath out. Upon that auscultation, I'm looking at a complete inspiratory phase, which inspiratory cycle, which is inhalation or taking in of air, or expiration, taking out of air. I will then compare one side with the other. I have done the anterior portion of the lung assessment. I will now go to the posterior of the back. Starting with inspection, palpation. When I'm palpating, as I didn't do in the front, forgot, but I do realize, I am looking for masses, any tenderness, or tactile fremitus, which is normal. I don't feel any masses. There's no tactile fremitus, and she didn't indicate by a jerk that it was uncomfortable for her. Next, I will percuss. Guess I need to take my stethoscope. She is hypersonus in her test for percussion. I will now listen or auscultate posteriorly. And I'm listening for one complete cycle. This concludes my assessment of the thoracic. I have inspected, looking for masses, any tenderness or tactile fremitus. I have palpated, looking for masses, and I have auscultated, listening. Her lung sounds are clear, no evidence of any disease processes. There's no tenderness, there's no swelling. Her capillary refill is brisk. I will now start the cardiovascular portion of the assessment. The cardiovascular and the lungs kind of go hand in hand. At the beginning of this assessment, because we're in an upright position, I cannot demonstrate this portion, but I would start by listening or by measuring the JVD, or the jugular venous pressure. The patient will be at a 30-degree angle, and I will have a ruler, knowing that 5 centimeters or less is the standard or a normal measurement for jugular venous pressure. One of the things that I'm aware you don't confuse the carotid artery measuring that, as that can give you an inaccurate measure. So I will start with the measurement of the jugular venous pressure. I will then inspect, and I'm looking, as she's a woman, I'm not going to feel, but I would palpate the apical pulse, and I'm aware that that can't be felt in overweight individuals. I have inspected, I have palpated. There is no percussion with the heart, as palpation takes over from that. I have looked at her for signs of swelling. There's no swelling. I will then feel for pulses, feeling at the radial, the brachial, the femoral on both sides, groins, the popliteal, the dorsalis pedis, which is on the top of the foot, and the posterior tibial, which is on the inner aspect of the ankle. I'm not going to feel, but when I felt her radial, it is bounding and a 2+ pulse. Bounding 2+ brachial. Dorsalis pedis, bounding 2+. Posterior tibial, bounding 2+. There's no evidence of swelling in either her feet, and I do know that I will check those pulses on both sides. Now I will start by listening to her heart tones. And I'm quite aware that when you listen to the heart tones, when you're listening with the diaphragm of the stethoscope, you are listening for S1 and S2, and when you're listening for with the bell of the stethoscope, that's S3 and S4. And S3 and S4 are an indication of murmurs. At the second intercostal face, which is I measured, this is the sternal, first, second intercostal space. This is aortic. I'm sorry, this is pulmonic. No, this is aortic to my right. I will go over to the second intercostal space to the left and listen for the pulmonic. Towards the sternal border, which is here, towards the left, I will be listening to the tricuspid. I will listen to the mitral at the base, or at the apex on the left, which is the apex of the heart. Now with the bell of my stethoscope, I will listen for the same things. S1 and S2 is normal. No evidence of S3 or S4, so there's no murmurs. I will now listen to her palpate her carotid pulses. they are bounding. I'm going to come on the other side and listen. And palpate. They are bounding. These are carotid. I will then take my stethoscope and listen for the carotid brewing. Coming to assess on the other side. This concludes my assessment of the cardiac and thoracic system. On each of those systems, I inspected, palpated, percussed, as there's no percussion on the cardiac system. Her lung sounds were clear, no evidence of any underlying thoracic disorder. Because I didn't measure the JVP, I can't give you an accurate measurement, but I know less than 5 is within normal limits. There's no swelling, there's no discolorations. Thank you.